All right, you're on.
All right. Well, welcome everybody to the JH Wiki webinar series and toolkit series. I'm Allison Agu. For those of you who don't know me, I'm an adult and peds ID provider here. And in my hat today, I'm the Part D director. So what is Part D or JH Wiki, which stands for Women, Infant, Children, and Youth Partnership for Excellence in HIV Care across Central Maryland? It is really, I like to think of it as a collaborative with the vision to achieve a more coordinated response to HIV care, right, by establishing mutually beneficial relationships that increase the quality of care that we provide as a community to those populations, women, infant, children, and youth. Our mission is to build upon existing structures and systems and create a dedicated network of providers and teams to coordinate across multidisciplinary systems with the goal of improving care for these populations. We developed this toolkit series last year in the midst of COVID to really try to think about how we can capitalize on all that we know as a network and to engage and amplify. So while the talk you're seeing here today and many of those before are from several people from Hopkins and beyond, our goal is if you see something and you think we're missing something, we want to hear from you because we'd like to engage you too and amplify your voices. Next slide. All right, so today it really is my extreme pleasure to have Jean Anderson here with us. I'll introduce her talk in a second. Next month in July, we'll have a talk about quality improvement in HIV clinical programs. And then Renata Arrington-Sanders in September, we'll skip August, looking at unique aspects of care for HIV and PrEP for LGBTQ youth by Dr. Sanders. Okay. So today's talk, it really is about women with HIV, preconception care, and current ART strategies in pregnancy. And it is really, she's going to tell me to stop talking, but I really do say it's my pleasure to have Jean Anderson with us today. Jean is a professor of gynecology and obstetrics and medicine at Johns Hopkins. She spent much of her career caring for women living with HIV and developing innovative care models. She founded and continues to direct the Johns Hopkins HIV Women's Health Program since 1988. Provides care to over 8,000 women and really is a leading program nationally and internationally for how we care for women. She served on the U.S. Preventive Health Services Task Force for Perinatal HIV Guidelines since its inception in 1999 and continues to be on that task force for prevention and management of opportunistic infections. She co-chairs the CDC HRSA Advisory Committee for HIV, Hepatitis, and STIs, and is a member of the HIV Expert Work Group of the American College of Obstetrics and Gynecology. She's a senior technical advisor for JPIGO, director of Johns Hopkins Global Women's Health Fellowship, and really has worked internationally on focusing on HIV and prevention of cervical cancer. Really, it gives me my extreme pleasure today to introduce Jean Anderson, who's a friend, a colleague, and she tells me she's retiring in August. I refuse to let her go, so I'm grabbing onto her ankles so she can stay and continue to advise, and really looking forward to what you're going to talk with us today about, Jean. So take the wheel.
Thanks, Allison, and thanks for that very kind introduction. It's a pleasure to be with you all. And what I'm going to talk about today is something I feel really strongly about, which is about about preconception care and some of the current antiretroviral therapy strategies in pregnancy, and sort of which continue to evolve as we get more experience. Next slide, please. So I want to review, first of all, just current epidemiology related to mother-to-child transmission of HIV, discuss the importance and what preconception care consists of, talk a little bit about where our missed opportunities for prevention of mother-to-child transmission are today, and discuss current recommendations for use of ART in pregnancy. Next slide. So this is sort of a real success story. This is the reduction in perinatal HIV infections in the US from 2014 to 2018. It obviously started way before that, but for the last year, 2018, for which we have numbers, there were 65 babies who were identified as having perinatal HIV infection. Next slide. So a huge success story. It is estimated that currently about 5,000 US women living with HIV give birth each year. But we have been able, and I'm going to talk about why, we've been able to decrease the mother-to-child transmission rates to significantly less than 1% in the US and Europe and other high-income countries. And this is related to a number of things. First of all, it's the recommendation for universal HIV testing in pregnancy, or opt-out testing, where HIV testing becomes a routine part of the standard prenatal labs, unless the woman refuses, which is rare these days. Secondly, is for women who are identified as having HIV, they all are treated with combination antiretroviral therapy, not AZT alone, as we did, a decade and a half ago, but more than that now, 2 decades ago, but with effective combination regimens. Thirdly, and I think this is less important, we do C-sections for prevention of HIV, but really the only situation we do that is women who have not been able to suppress their viral load below 1,000 copies by the time of delivery. And then the fourth and fifth components I'm not really going to talk about, but these have been key for getting to where we are today. Appropriate infant antiretroviral management, including antiretroviral prophylaxis, and avoidance of breastfeeding. So it's really, we're at the point where it is a realistic goal, and it's the CDC goal, to eliminate mother-to-child transmission in the US. And by elimination, it doesn't mean absolutely zero, but an incidence close to zero, less than 1 to 100,000 births. Next slide. So this is over from 1993, which was really prior to the results of the PACTG 076 study, which was really remains one of the landmark clinical trials in HIV medicine. And this was conducted in pregnant women, where women were started usually at about 14 weeks of pregnancy on AZT or ZDV alone. That was continued throughout pregnancy. They got AZT intrapartum, and then their babies got it for 6 weeks. And what you can see, and I think, Marinas, if you could click, it'll show where basically a 2/3 reduction in transmission rates, which at baseline are roughly around 25%. That was cut by 2/3 with zidovudine alone. And then what you see is a continued decline as we got better drugs, and we realized the importance of combining drugs effectively to treat. So again, the most recent studies out of the UK and the US show rates of about 0.3 to 0.9%. Next slide. We understand a number of things. Transmission can occur really at any time during pregnancy and postpartum through breastfeeding. We think that the majority of transmission occurs around the time of delivery. And again, with prolonged breastfeeding, risk is significantly increased. This is really in the absence of therapy, antiretroviral therapy. Next slide. So we talk about cascades in medicine these days, and this is the perinatal HIV prevention cascade. So let me walk through this just a little bit with you. So first of all, obviously, we would like to prevent HIV infection in women and girls, but we know that we're not there yet, and that they need to be identified as having HIV. And ideally, this should be done prior to pregnancy. The CDC recommends that everybody be tested from between the ages of 13 and 64, at least once. And we know that individuals, men and women who are at risk, should be tested more often. So you can have these missed opportunities. Someone doesn't know she has HIV. She doesn't get preconception care when testing might occur. She becomes pregnant, and doesn't have prenatal care or shows up late to prenatal care. She is in prenatal care but doesn't get HIV tested. She gets HIV tested, it's positive, and she is not adequately treated with antiretroviral therapy. She has a high viral load, does not get a cesarean section. She breastfeeds her baby. And so you have this sort of Swiss cheese effect, if you will, where you can get to some of these barriers, but if you have one of these barriers, that is a hole in the system where the woman may become infected. Next slide. So this is a study that Steve Nesham published a couple of years ago now, looking at this perinatal cascade from 2005 to 2014. So this is, you see two columns. One is HIV exposed infants, but who remained uninfected, and then HIV infected infants. And you can look, and so again, this, even before this, is the testing. And I might say that we've, I think that in the US today, we've done a pretty good job now of incorporating routine testing into pregnancy, but there's still gaps. And that's still one of the major areas where we are missing opportunities to prevent perinatal transmission. And we know that the coverage, testing coverage, is poor for women who are in subgroups who are perceived by their providers and probably by themselves to be at low risk for HIV. If they are married, if they are white, if they are non-Hispanic, if they are multiparous, if you can think of some other things, but these are women who tend to be missed, particularly, I think, in private providers who are busy and don't think that they are at risk. But the bottom line is, you look at the proportion at once someone is diagnosed, those proportion in both the exposed, uninfected, and infected categories, what proportion had inadequate prenatal care or no prenatal care? What proportion got antiretroviral therapy during pregnancy or during labor, cesarean section, neonatal antiretroviral therapy, prophylaxis, breastfeeding, etc. And you can see in how that there's still a significant proportion of individuals in the uninfected category who have fallen through some of these cracks, but you can see that it's also pretty high in those who have HIV. Currently, you can see that maternal HIV diagnosis at or after delivery is roughly double to triple among those who have HIV infected babies than those who have uninfected babies, though they're exposed. Next slide. So there are other missed opportunities for prevention of mother-to-child transmission. Lack of early and sustained viral load suppression. I'm going to say a little bit more about this in terms of antiretroviral therapy, but that involves access to appropriate regimens and access and treatment early enough in antenatal care to prevent transmission and to lower viral load. Maternal genital tract infection. We know that that can be associated with viral load in the genital secretions, even if the plasma viral load is undetectable, and that presents some risk. And then one thing I want to particularly point out is the role of acute or primary HIV infection in pregnancy. This is a particular risk because a woman who becomes infected in pregnancy, number one, is less likely to be diagnosed. She may be negative at her initial testing. And then even above that, she is at increased risk over women who have chronic HIV for transmission to her fetus or infant. And then a third issue that's significant for the woman is to know that pregnancy has been shown to be a period of increased risk of HIV acquisition for the woman. So I think we tend to not think about that. We don't talk about safe sexual practices when appropriate in pregnancy, but we should be. Next slide. So let me turn to preconception care. First of all, what can you do as providers? I think that for those of you who are not taking care of the pregnant woman, but you're taking care of women who have HIV or their partner, is to ensure that both partners in the couple are tested so that those who are HIV positive can be have effective treatment, because we know that that treatment is an important method of prevention for perinatal transmission as well as other types of transmission. But also if partners are uninfected, and this includes pregnant women, the use of pre-exposure prophylaxis. I'm not going to talk about that today. But it's also an opportunity to discuss safer sexual practices. I think we don't talk about that enough these days in the era of U equals U. But I'm still seeing a lot of sexually transmitted infections in women of childbearing age. And we know that that is an increased risk of both acquiring HIV for the woman, but it may also be a risk of transmission to the baby. And then I think it's important for those of you who are seeing women with HIV to assess their childbearing plans and desires, not just once, but on a regular basis. If she says, I do want to have children, but not now, you want to ask about, okay, let's talk about that. When do you want to have children? And really promote safe birth spacing. It's been shown in the past that having at least 1 and possibly 2 years between births is ideal to allow women to recover from the stresses of childbirth, to deal with caring for a new baby, to build back their blood supply, etc. And if she doesn't desire pregnancy, you want to help her ensure access to effective contraception. And I think we're always happy to do preconception counseling for women and for their partners if they desire to conceive. And I'll talk a little bit about that, because I think that's important, not just from the counseling aspect, but there are some critical actions that may be important to help her have a safe pregnancy. Next slide. So why, again, is preconception care important? Well, we know now, particularly in the era of antiretroviral therapy, that fertility desires and intentions among women living with HIV are not that different from those without HIV. And in fact, a study that was done, it's now about 13 years old, but it looked at pregnancy rates after in the era of antiretroviral therapy, and found that there was a 150% increase as compared to before the era of antiretroviral therapy among women living with HIV. And in the same study, there was only a 5% increase among women who didn't have HIV. So, and this is a success story. It means that women are feeling a lot more hopeful about their lives if they have HIV and they want to have a normal life, including children when they desire that. But we also know that there are high rates of unintended pregnancy. In one study, 85%, this is of about 380 women living with HIV, about 85% had had one or more unplanned pregnancy after knowing that they had HIV. And I might mention, we're not going to talk about contraception, but HIV infection does not preclude the use of any effective contraceptive method. But another reason to talk with them about contraception, and we do that in the context of preconception care, is that there are some drug-drug interactions between certain antiretroviral agents and certain hormonal contraceptive methods. And even though that's a pharmacologic effect, we do worry, and it has been shown in a couple of instances, that may reduce the efficacy of those contraceptive measures or increase the risk of adverse effects. And then finally, a reason to do it is for safety considerations. Pregnant women are in general excluded from antiretroviral therapy clinical trials. So most of our experience in pregnancy comes from experience, women who are become pregnant either intentionally or unintentionally on certain regimens. And we try to capture that experience, but we don't have the robust clinical trial data we have for other adults. And then another issue related to safety is pregnancy is often not recognized until either during or after the greatest risk of potential birth defects. Next slide. Again, why is it important? Efficacy. Some antiretrovirals have lower drug levels, particularly in late pregnancy, and that could potentially increase the risk of loss of viral suppression. So when we think about optimizing somebody's regimen prior to pregnancy, that is a consideration. And so then finally, for women who wish to become pregnant, the choice or modification of antiretroviral therapy still aims, as in the general adult and adolescent population, for sustained viral suppression prior to conception, because that's associated with the lowest risk of perinatal HIV infection, and it optimizes maternal health and helps prevent transmission to others. Next slide. So just very briefly, when I talk to women in terms of preconception counseling, it's not just about HIV, but it certainly focuses on HIV in many ways. So I want to get a complete history of their HIV, when they were diagnosed, do they have a history of OIs, what's their current CD4 and viral load, their past and current ART history, including resistance testing, adherence challenges. But then I also want to know their OB history. How many times have they been pregnant? What happened to those pregnancies? Did they have complications? Did they have premature baby? Did they need a C-section, and why? And what is the status and ages of their current children? I want to know about other chronic medical conditions and other medications. And I want to know the sort of psychosocial frame of their life, the social determinants of health. Who have they disclosed their HIV to? Do they have a history of intimate partner violence? Do they have depression? Do they have a substance use disorder? And so the goal is to ultimately, as I've said before, is to prevent unintended pregnancy, to promote good birth spacing, to optimize maternal health prior to conception, which also then will optimize health during pregnancy. Next slide. So let me turn to the use of antiretroviral therapy in pregnancy. And first of all, just some general principles. And these are taken directly from the Department of Health and Human Services perinatal HIV guidelines. So first is that ART is recommended for all pregnant women to prevent perinatal transmission, but also to optimize the health of the mother. And we know that perinatal transmission is directly related to HIV viral load. An undetectable viral load, at the time that this study from the UK and Ireland was published, this was less than 50. We know now we can measure down to less than 20. But the risk is, as I said, below 1%. Furthermore, we know that early initiation of antiretroviral therapy increases the likelihood that she will have viral suppression by the time of delivery. So it further reduces the risk of transmission. And in this study from 2015 from the French perinatal cohort, they looked at women who had undetectable viral loads at delivery. And then they looked at when they were started on antiretroviral therapy. They had no transmission in their cohort when they were already on antiretroviral therapy by the time they got pregnant. They had 0.2% with first trimester starts, and then you saw it goes up a little bit. And I think the take-home message when we first, if you looked back at the first iteration of these guidelines, it was recommended that you delay starting antiretroviral therapy until after the first trimester. That's no longer true, because I think it's studies like these that have emphasized how important it is to start as early as possible. We do perform HIV drug resistance tests at the beginning of pregnancy if someone is not on therapy, or if they have if their viral load is above 500 to 1,000. So we start it, but we don't delay starting antiretroviral therapy while waiting for the results. We try to use their history of their therapies, and if they've had resistance testing or problems, we go from there. And again, antiretroviral therapies, besides lowering viral load, we know that they also have, they work through a pre and post exposure prophylaxis mechanism for preventing perinatal transmission. Next slide. So initiate ART as early in pregnancy as possible. The choice of antiretroviral regimen is informed by the current adult treatment guidelines, but there are special considerations in pregnancy. So what do we know about the potential risk of birth defects with certain agents or other adverse pregnancy outcomes? Is there available pregnancy-specific pharmacokinetic data? So do we know that the doses that are appropriate for adult and adolescent non-pregnant women is adequate for women in pregnancy? And then there are also other factors. One of the things that can be limiting early in pregnancy is nausea and vomiting, morning sickness. But you have to consider other comorbid conditions, just as you would with any other individual. Next slide. We continue antiretroviral therapy throughout pregnancy, including the intrapartum period. And in general, women who come into pregnancy who are already on a regimen, we continue it, assuming it's effective, they're suppressed, it's safe, and they're tolerating it. And really, the main exceptions are those for drugs that are really no longer recommended due to toxicity. I haven't seen anybody on D4T or DDI in years now. If viral suppression is not achieved after an adequate period of time on treatment, then we assess it just like with any other individual. We first of all think about adherence, because that's the number one issue. But we look at tolerability. We assess dosing, particularly if it's a drug that we know has some PK changes in pregnancy. We look at if there are food requirements and are they adhering to those. We look at potential problems with absorption, say with other medications, or potential drug-drug interactions. And again, if we assess the viral load late in pregnancy at around, usually around 36 weeks of pregnancy, and if that's the viral load that we make the decision about mode of delivery. If it's over 1,000, the woman has a scheduled cesarean section at 38 weeks. And by scheduled, I mean we schedule it. We don't allow her to go into labor. And then again, as we mentioned, all exposed infants should receive appropriate ARV drugs for prophylaxis. Next slide. So this slide and the next slide are the current categories of drugs and what we think about them for use in women who are trying to conceive and during pregnancy. So the first category are those that are preferred, and to make that category, they have to have been shown in adults and in clinical trials that they're effective, that they have a durable effect, that they're well tolerated, that they're reasonably easy to use. So that's number one. Secondly, is there needs to have been pharmacokinetic studies done in pregnancy so that we can know for sure if the dosing that is recommended in general is appropriate. Thirdly, it has to have a favorable risk-benefit balance as compared to other options. And then fourth is that we have some information about acceptable safety outcomes for pregnancy, for fetuses and infants. So that's the preferred category. The alternative category is one step below that. And generally means that it's clinical trial data, it shows it's good, it's efficacious, but that the data in pregnancy is just more limited, but there's no red flags, as it were. Next slide. And then you have three more categories: insufficient data to recommend. And you see that in a lot of drugs, and it's simply that we don't have enough information in pregnancy. We may not have PK data or safety data. We just don't have enough experience. But these are drugs that are effective in adults and approved for use in adults. But we don't say never use them, but it's important to know the limitations of our knowledge. Then there are the category not recommended except in special circumstances. And this is usually older drugs or regimens that are either the woman's already on or that you may need to start her on because she has extensive ART experience and your options are limited. And so you're willing to take a slightly greater risk than to be able to try to help her reach and maintain viral suppression. And then not recommended drugs are limited to those that aren't effective, or that there are potentially serious maternal or safety concerns, or PK studies have demonstrated that drug levels are lower in pregnancy and a greater risk of viral rebound. So these are sort of the categories. Next slide. And just some key points. So typically, as we get more experience, and a lot of the experience is simply real life experience, it's not through clinical trials. But as we get more experience with specific agents, as well as PK studies are done, drugs tend to migrate from the insufficient data group towards alternative and ultimately preferred categories. So that's one of the reasons you want to stay up on that. Things continue to evolve, and drugs that a year ago were considered insufficient may be preferred agents now. So it generally happens parallel to the changes in the adult guidelines, but it's behind. In some cases, the drugs may move in the other direction from preferred to alternative, and that's simply because better drugs become available. And I would urge you and urge all of us to use caution in unilaterally restricting the choice of regimens in women of childbearing age, or changing regimens that are working in women who present in pregnancy, because it may reduce their likelihood of achieving sustained viral suppression. This needs to be a joint decision-making venture with mothers and mothers-to-be. It's not something that we simply proclaim on high. We want this to be a discussion and really explain rationales and answer questions. And then remember the difference between absence of data and evidence of harm. And I think that comes into play in many cases. If someone looks up and says, oh, this isn't preferred or it's not alternative, I need to stop it and let's just see what happens. You don't want to just stop a regimen, period, because she's going to rebound. And it may be that when you put together all the different options, the drug she's on is the best option. Next slide. So this slide and the next slide, maybe the next two slides, are sort of condensations of the current iteration of the perinatal guidelines. I have a website address at the end. Many of you already know it, but I think it's a superb reference. And this website contains all of the Public Health Service guidelines for HIV. But what this is a table from the perinatal guidelines, and what it does is look at specific drugs, which of course are going to be in a part of a regimen, and then look at different situations. So you have, starting on the right side, you have someone who you're seeing for preconception care. They are not pregnant, but they want to conceive, trying to conceive. And then you have 4 categories of women who are pregnant. From the left, women who are pregnant and have never been on antiretroviral therapy before. Secondly, those who are pregnant, but they're on a well-tolerated, effective regimen. Thirdly, pregnant, they're not on therapy now, but they have been on therapy before and they're restarting antiretroviral therapy. And then fourthly, a woman who's pregnant, who is on therapy, but it's not working or she's not tolerating it. So you can see, I'm not going to go over each of these, but I'm going to go over just a couple that I think are important. But you can see where they fall out, those that are preferred, some not recommended. I'm going to go over those. I think the ones I want to point out on this slide, and I'm going to say more about dolutegravir in a moment, because there's been a lot of controversy about this over the last 2 to 3 years, because of some data I'll show you in a minute. And so a lot of people were very afraid to use it in women who were trying to get pregnant or pregnant. But I wanted to point out that that is now a preferred regimen for all of these categories. I also want to point out that Biktarvy, which is a wonderful drug and an effective drug and one of the most common regimens that we see, is still considered insufficient data to form a recommendation in pregnancy. And so this is a perfect situation where preconception care would be, I think, important. It's not that there's been, I want to, again, absence of data doesn't mean presence of harm, but it's simply that we don't have the data, we don't know, and there may be better options, and sometimes they're not. I'm going to say more about elvitegravir boosted with COVID. It's not recommended because of PK issues, because of lower drug levels, and some studies that have shown loss of viral suppression. Atazanavir boosted with ritonavir and darunavir boosted with ritonavir are in the preferred category. Lopinavir boosted ritonavir used to be in the preferred category, but now it's been demoted, and just because they're better drugs. And those that are boosted with COVID are generally not recommended, again, for PK issues. Next slide. So here's the NNRTIs, and the I wanted to point out that efavirenz, those of you who've been in this field for a long time, remember when efavirenz was very controversial, and people said, do not use efavirenz in women of childbearing age or in pregnancy because of concerns about neurotube defects. Well, now it's an alternative agent, which means it's perfectly fine to use in pregnancy. And I'll say a little bit more about that. And then one other thing I wanted to just point out, or two things actually. TAF, which was insufficient data, is now alternative, and I expect that in the next guidelines this is going to be further upgraded because, again, we've had more experience with TAF. Zidovudine, however, was downgraded from a few years ago now, from preferred to alternative, simply because they're better drugs, they're better tolerated drugs. Next slide. And this is just, I'm not going to go over all of this, but I mentioned pharmacokinetic concerns during pregnancy. And so let me just point out a couple of things. First of all, as I just mentioned a minute ago, boosting with cobicistat is generally not recommended because of the risk for lower drug levels and viral rebound in late pregnancy. And of course, if the majority of the transmission occurs in late pregnancy, that's the time you really want to have someone suppressed. Some other things to point out: darunavir, ritonavir, which in adults is often given once daily, that is not recommended in pregnancy. It's given twice daily during pregnancy. Similarly, for lopinavir, ritonavir, even though we don't use it that much anymore, once daily dosing is not recommended. Rilpivirine has PK values, blood levels that are highly variable during pregnancy, and simply it's important to monitor viral load very carefully. And in fact, any of these, like elvitegravir, COVID, again, concentrations are reduced with standard doses during pregnancy, but higher than standard doses haven't been studied. There is some data on higher doses that may be used in atazanavir. Bottom line is, I mean, these are things I think most of you may not be dealing with, but recognize that these are potential issues and investigating them. And if you are managing a woman who is pregnant on these regimens, that needs to be discussed with someone who has experience with HIV in pregnancy. Next slide. Some of you may be asking about long-acting cabotegravir and rilpivirine. The perinatal guidelines group is discussing that currently, but I can tell you, obviously, there's insufficient data. We simply don't have data in pregnancy. We also, in general, 2-drug regimens during pregnancy are not recommended. And the current guidelines call for 2-drug regimens to be switched or additional agents to be added. And I think the third issue that I didn't put in this slide, but if somebody gets pregnant on these regimens, it's how do you manage that? Because it's not like you can just stop cabotegravir and rilpivirine. And I think that the adult guidelines have some guidelines about that, which would probably be followed in pregnancy as well, but we simply don't have the pregnancy specific information. Next slide. So let me say a little bit more about dolutegravir. In the interest of time, I'm going to go through this very quickly, but in this, dolutegravir was being used and touted, and then an interim analysis, which was unplanned, of an observational surveillance study in Botswana, which was reported in May of 2018, found an unexpectedly high rate of neural tube defects in women who were exposed to dolutegravir in pregnancy, particularly early pregnancy around the time of conception. It was 0.94%. Now this slide represents an update for that. So they got more individuals, you can see the number, and they looked at dolutegravir, they looked at conception, they looked at non-dolutegravir regimens, and they looked at efavirenz. And then they looked at during pregnancy and HIV negative women. And you can see the risk in the top part of the slide. So still a little higher, but 0.3% rather than 0.94%. Next slide. So this is the most recent updated analysis that I'm familiar with, of April of last year. And so it's continued to come down. You can see that with dolutegravir, this is again with early or periconception exposure, 0.19%, as compared to any other ART at conception, 0.11%. Efavirenz was very low, 0.04, and HIV negative, 0.07. So sort of the bottom line is the risk of neurotube defects in infants exposed to dolutegravir around the time of conception is still higher, and it was statistically significantly higher as compared to efavirenz or to those women without HIV, but it was not significantly different statistically from those who were on other ART exposures. And as I said, it's lower than originally observed. Next slide. And this is just from the antiretroviral pregnancy registry, which I think most of you are familiar with. Overall, the neurotube defect prevalence with periconceptual antiretroviral exposure is 0.03%. That's consistent with the low neurotube prevalence, defect prevalence in most developed countries with food fortification, particularly with folate. But there weren't sufficient numbers of integrase inhibitors to rule out or confirm any potential neurotube defect association. Next slide. So I think to put this in perspective is that there are other risks that we know that may cause neurotube defects. And neurotube defects are serious defects. So that's why we're taking this extremely seriously. One of the things that's been raised is that in Botswana, where this study was performed, they do not supplement food with or fortify food with folic acid. And we know and have known for some time that folate helps prevent neurotube defects. It's not a treatment, it helps prevent. But there are other risk factors for neurotube defect, including diabetes, maternal obesity, hyperthermia, and certain drugs, including valproic acid, which is a seizure medication. So I think that whenever you think about risk of any given defect, you want to think about what are the confounding factors, what are the things that may also play into that risk. And there's usually a background risk of any given defect. So you want to be careful about automatically attributing it to a particular drug when there may be other factors involved. Next slide. So all of this is to say that a lot of thought has been put into this, a number of studies, And this is one of the reasons why, the next couple of slides, I'm going to show you the other main reason why dolutegravir is such an important part of the armamentarium. But it's now considered preferred throughout pregnancy, and in most cases should be continued even when the woman comes in the first trimester. The background risk of neurotube defects in the general population is 0.07%. So there is a background risk. I just mentioned folic acid lowers the risk of neurotube defect, and in the US, food is routinely fortified with folate. The other thing is that most neurotube defects occur very early in pregnancy, by 6 weeks gestation. Often that's before the woman even knows she's pregnant, much less has come in for care. And as I mentioned a couple of times before, changing therapy unnecessarily can result in viral rebound. Next slide. So this slide, and I think the next slide, are really one of the real things that's very important to know about the integrase inhibitor class, including dolutegravir and raltegravir. And that's that they can lower viral load very rapidly. This study, it was a phase 3 trial where dolutegravir versus efavirenz as part of the regimen were initiated late in pregnancy, so late, greater than 28 weeks. And that's when you really want to get the viral load down as soon as possible to minimize risk. And dolutegravir was much faster than efavirenz, as you can see. Next slide. This is another study that actually looked at raltegravir, and this was an open label randomized controlled trial. This was a little earlier in pregnancy, so raltegravir versus efavirenz based regimens. And again, when they looked at the primary efficacy outcome, viral load less than 200 copies at or near delivery, raltegravir was superior to efavirenz. And that was primarily in those who enrolled later in pregnancy, that you want to get their viral load down faster. And you can see that the median time to lowering the viral load to this level was 8 days with raltegravir versus almost double that with efavirenz. And safety issues were similar. Next slide. And then this is the last study I'm going to mention. This was just published recently, looking at dolutegravir versus efavirenz and TDF versus TAF in pregnancy. And sort of the bottom line again, if you look on the left side of the slide, the dolutegravir arms were more likely to have a suppressed viral load at delivery. And if you look on the right side of the slide, it looks like the TAF containing regimens, so these were dolutegravir, FTC, and TAF, in general had lower risks of adverse pregnancy outcomes, including preterm delivery and small for gestational age. Next slide. So to wrap up, key take-home points. There are special considerations for prescribing ART to women of childbearing age. These relate to safety, changes in PK, drug-drug interactions between ARVs and some hormonal contraceptive methods. So it's important to engage women prior to pregnancy to be able to identify and address these issues to help her ensure as safe a pregnancy as possible, or to prevent it or delay it. Although current evidence suggests a possible small increase in neurotube defects in women who conceive while receiving dolutegravir, this drug is considered a preferred antiretroviral agent throughout pregnancy. PK issues with some drugs in pregnancy may warrant increase in dose or closer viral load monitoring. So those are some key considerations. Next slide. And I think this is just, which I think, again, most of you probably know about and consult, but this is the site of all the DHHS HIV guidelines, including the perinatal guidelines. And these are updated regularly. We have a meeting of the perinatal guidelines group every month. They are updated at least yearly and sometimes more frequently. So thank you very much. I will stop there.
Oh, Jean, you never disappoint. Thank you for that really a historical, perspective, but also taking us, where we are today and the most salient details and features that we need. Really love that. We have a couple questions in the chat. Lots of Siobhan. So I think one of the quick questions was, is the risk the same if we use viral load less than 200 versus less than 20 or 50 in terms of transmission? And if you can comment on that.
Yeah. Well, I think that, the reason less than 200 is often used to indicate suppression is because you can have these little blips that are probably meaningless. And again, the studies related to C-section show less than 1,000. There's no particular benefit for doing in terms of preventing transmission. I think there are, I'd have to look at the most recent studies, but I mean, my thought is the lowest you can get, the better. And so our goal is obviously total suppression. Realizing there may be a blip here and there for a variety of reasons, but if she can get down to less than 20, then it's also a good sign she's adherent. And if she can maintain that. So the risk, I think, if you had enough patients, and it's a little hard to look at that now, but if you had enough patients, I would say that you probably could stratify and show that it's lower risk with less than 20, even though less than 200 is low. And then I see, I'm just reading the questions. Siobhan also asked about, is this long-acting cabotegravir or ribavirin? Yes?
Yeah.
So again, I think we're still trying to figure that out. And right now we would probably, in fact, we have had a discussion in the perinatal guidelines and I can't, it has not been voted on yet. So I can't give you any specific guidance, except it should come out very soon.
Okay, yeah, because I'm thinking, it's gonna be out soon, and it's already approved. It's just sort of the logistics, but worrying about the idea that they really are remaining in the body for a long time. So if they come in on that, and they're not undetectable, whatever. So there's a lot of, I think in the preconception counseling, maybe this should be brought up for patients now.
Exactly. And I think that, it's, as I said, it's, the CAB and rilpivirine, it's 2 drugs. We don't recommend 2 drugs only in pregnancy. And, there's going to be insufficient data in pregnancy. I mean, I can tell you it's either going to be in the insufficient data or do not recommend at this point in time.
Right, because the people it's going to affect are going to be the people who are not expecting to get pregnant.
Exactly.
And on that.
So as you said, it's an important reason for preconception care and counseling. But I think that, we will see women come in on this regimen. We're going to have to think about how to do it and either continue it with close monitoring of their viral load or get them off and do that carefully.
Thanks.
Awesome. I don't see other questions in the chat, so I have to ask one, and it could be a teaser. The guidelines, and where I'm going with this one, have been, for years really talked about breastfeeding and being absolute no about breastfeeding. So maybe you can drop a little bit of a teaser in terms of how we may be approaching breastfeeding among HIV positive women at this point, and to the late people to come to a future talk.
And tee it up for you, Allison. Yes, this is something that we are seeing more women who want to breastfeed. I think for a lot of reasons. Many of them are immigrants from countries where that's the norm, where there's also more stigma, so they haven't disclosed to mothers or mother-in-law, and they're also very aware of the benefits of breastfeeding, and other women as well want that experience. So we are trying to engage our nurse manager. I think she is on, Allison Livingston, for the nurse history, takes an extensive history, and that's part of the history as to what their intentions are. We really try to approach this from a harm reduction approach and involve Dr. Agwu and her colleagues in pediatrics, the lactation services, our service, to really engage the woman and her partner, if possible, about the reasons, about what, we're clear about what the recommendation is, which is not to breastfeed. But we also know that some women are probably pretty good candidates for breastfeeding if they want to. And so we want to help them do that in as safe a way as possible. Is that enough of a teaser for you?
That's enough of a teaser.
Okay.
Jean, recognizing the time, I want to say thank you so much for an amazing talk. I want to acknowledge members of the team, your women's program, who are fantastic. I see Rose, I see Allison Livingston on. I think that those were in terms of people who are from the team, but really the work you've done. And then I wanted to put our camera on Marina's Terra Forte for really organizing and being my partner in crime for all of this. And please, when you get the evaluation after this event, please do fill those out and give us feedback about what else you want to see from us. And again, including what you feel like you have expertise to share. Again, it's to engage and amplify. With that, happy Juneteenth. Please take the time to celebrate tomorrow. And we hope to see you next month for quality improvement. Really, thank you. Have a great day, everybody.
Thanks.
Thank you, everybody.
Thanks.